Rheum, pathology, vasculitides. All right, so the vasculitides are autoimmune reactions against vessels, and it's broken up into large vessel, medium vessel, and small vessel vasculitis. So let's start off with large vessel vasculitis, giant cell temporal arteritis. So this is one of the higher yield large vessel vasculitides, and we already discussed it a little bit with its association with polymyalgia rheumatica. Now, what I want you to take away is one, females greater than 50 years old are highly associated with giant cell temporal arteritis. Number two, the symptoms and signs you'll see associated with this is unilateral headaches, temporal artery tenderness near the temporal region of the head, and jaw claudication, so pain with chewing. It may lead to irreversible blindness. That's number three. The very scary thing is that it can cause irreversible blindness because it can cause ischemia to the optic nerve. And once again, its association with polymyalgia rheumatica is relatively in yield, okay? Now, it most commonly affects our carotid artery branches. And what you want to know is that it has focal granulomatosis inflammation. So granulomatous inflammation with highly elevated ESR and IL-6 levels, okay? And the way you want to treat this is with high-dose glucocorticoids prior to temporal artery biopsy. You have to do the high-dose glucocorticoids before you do the biopsy to prevent blindness. So you really, really have to give them high-dose glucocorticoids. That's the first thing you need to do. And then you can follow it with a temporal artery biopsy in order to diagnose temporal arteritis, okay? So kind of the main takeaway here is elderly female with headache, pain on chewing, and severely elevated ESR with an increased risk of blindness is giant cell temporal arteritis. All right. Next is Takayasu arteritis. Takayasu arteritis is going to be usually in Asian females less than the age of 40. And the way that they call it pulseless disease because these patients are going to present with weak upper extremity pulses. All right. Now, you're going to see that this is also granulomatous thickening and narrowing of the aortic arch and proximal great vessels. So this is going to include the great vessels. This also has an elevated ESR because it's an autoimmune inflammatory process. So for the overall takeaway for Takayasu is an Asian female with pulse abnormalities and with association of the great vessels. And there could be a Brui herd over these great vessels. All right. That's Takayasu. So that's all of our large vessel vasculitides, all right? Very straightforward. Giant cell temporal arteritis is very high yield. You need to know this. Remember, it's an elderly female with headache, pain on chewing with an increase in ESR. And the main thing that you're fearful of is blindness, okay? So you have to give them high-dose glucocorticoids before the temporal artery biopsy, all right? Remember that it's a granulomatous inflammation with an increase in IL-6 is what you'll see. And the blindness is caused by ischemic optic neuropathy. Don't forget that. All right, next is going to be our medium vessel vasculitis or vasculitides. The first one is Buerger disease. Buerger's disease is Buerger. I just don't want you to confuse it with the other Buerger disease, which we've discussed previously in renal section. So what this Buerger disease is a medium vessel vasculitis, and it's associated with heavy tobacco smoking, usually in males less than the age of 40. It's going to cause intermittent claudication, and it's going to lead to gangrene and auto amputation of digits. Okay, and so you're going to see superficial nodular phlebitis as well. And so on histology, you're going to see inflammatory intraluminal thrombi that spare the vessel walls. Okay, that's something that they might ask about. Now, the treatment is smoking cessation. So the quick, hard overview of Buerger disease is a smoker with nasty hands and feet because of auto amputation of digits secondary to gangrene. All right, so if you ever see a severe smoker with that, then you know that you could potentially be talking about Buerger's disease. Next is going to be Kawasaki's disease. Kawasaki's is usually in children that are Asian less than 4 years old. So Asian children less than 4 years old, you're going to see conjunctivitis, rash, which is first polymorphous, then desquamating, and then adenopathy, usually cervical. They have a strawberry tongue and hand-foot changes like edema and erythema, and lastly, a fever. All right? All of those symptoms are very high yield. Okay? And what you want to take away from this, in my opinion, is the conjunctivitis. Why? Because there's no conjunctivitis in comparison to, let me take a step back. What people usually confuse Kawasaki's with is going to be our group A strep, right? Strep pyogenes. And so they get it confused with this because it can often similarly present to our scarlet fever, okay? And so scarlet fever does not have the bilateral conjunctivitis, which you'll see. That's non-exudative. And scarlet fever does have a sore throat. If they give you a patient that has no sore throat, then that's Kawasaki's. If it's sore throat, then that's going to be scarlet. Okay? So that's kind of the differentiation that you need to make. Now, what you need to know is that you may develop coronary artery aneurysms. So patients with Kawasaki's, the most feared complication is coronary artery aneurysms. Okay? And that can cause thrombosis and rupture, and it can cause death in the child. So the treatment is going to be IVIG, IV immunoglobulins, and aspirin. This is the only time that the child can receive aspirin because a feared complication is going to be Rey syndrome in a child that receives aspirin. But this outweighs the risks of Rey syndrome because you don't want the child to die from coronary artery aneurysm. All right. So Kawasaki's key takeaway: an Asian child less than 4 years old comes in with skin, lips, and tongues being affected. They have differentiate from the scarlet fever by no sore throat and the presence of conjunctivitis. Okay. So remember, that's your key takeaways. Don't forget the coronary artery aneurysm. It's very scary. Next is polyarteritis nodosa. What you need to know about polyarteritis nodosa is that it's associated with hepatitis B. Okay, so you have Hep B association. Usually you're going to see transmural inflammation with fibrinoid necrosis and probably like tons of renal microaneurysms and spasms. Now, what you're usually going to see also is renal infarcts, bowel infarcts, and the lungs are going to be spared in polyarteritis nodosa. So that's very, very key to understanding that. You're going to treat it with glucocorticoids, okay? So the overview here, patient has Hep B positivity with nerve deficits, skin nodules, purpura, and renal failure because, and they could have also renal infarcts and bowel infarcts. You're going to see a string of pearls on kidney biopsy, and you're going to see segmental transmural inflammation with fibrinoid necrosis. The lungs are usually spared in polyarteritis nodosa. Okay, so those are your key takeaways for polyarteritis nodosa. Next, we're going to go to small vessel vasculitides. For small vessel vasculitides, there's honestly, it can be confusing, but we're going to just go through each one of them. So the first one we're going to talk about is eosinophilic granulomatosis with polyangiitis. For this one, you're going to see it's also called Sturge-Strauss syndrome. So that was what it used to be called, but it's now called eosinophilic granulomatosis with polyangiitis. Okay, so if you see Sturge-Strauss syndrome, it's the same thing. And what it's going to present as is late onset asthma, sinusitis, and skin nodules or purpura. Okay, and they can have wrist and foot drop with peripheral neuropathy. Okay, they can also present with elevated eosinophils, which is very key. They have granulomatosis or granulomatous and necrotizing vasculitis with an MPO-ANCA, P-ANCA positivity. Okay, so key takeaways here for eosinophilic granulomatosis with polyangiitis: asthma, sinusitis, eosinophils, and P-ANCA positivity. Okay, so that's what I want you to know for eosinophilic granulomatosis with polyangiitis. Also know the other stuff I talked about, but those are very key. Wrist and foot drop also is incorporated in there. And remember, if they say P-ANCA positivity, they could also call it myeloperoxidase positivity because remember, MPO is the same thing as P-ANCA. MPO-ANCA and P-ANCA go hand in hand. Next is granulomatosis with polyangiitis. What you're going to see is more upper respiratory tract infections like perforation of the nasal septum. You can see chronic sinusitis, otitis media, and mastoiditis. Lower respiratory tract, you can see hemoptysis, cough, and dyspnea. You also will have renal involvement. Okay. Now, the triad that you're going to likely see is focal necrotizing vasculitis, necrotizing granulomas in the lung and upper airway, and necrotizing glomerular nephritis. These are C-ANCA, PR3, ANCA, and C-ANCA, which go together. They want you to know that that's an anti-proteinase 3 antibody. Okay. So the key takeaway, sinus, kidneys, and lungs are involved with a C-ANCA positivity. Granulomatosis with polyangiitis is also known as Weckner's. Okay? So far we have eosinophilic granulomatosis with polyangiitis, which is just asthma with elevated eosinophils and P-ANCA positivity or MPO-ANCA positivity, which is just myeloperoxidase. Granulomatosis with polyangiitis is more so sinuses, kidneys, and lung involvement with C-ANCA positivity or PR3-ANCA positivity, which is anti-proteinase 3. And the other one that is high yield and can be confusing is microscopic polyangiitis. Okay, microscopic polyangiitis is going to be necrotizing vasculitis, commonly involving the lungs, kidneys, and skin. Okay, now what you have to know is that there's no sinusitis present. So there's without nasopharyngeal involvement for microscopic polyangiitis. It is also non-granulomatous, so there's no granulomas present as well. It's MPO, ANCA, and P-ANCA, and that is your overall microscopic polyangiitis. So solely kidneys and lungs involved is going to be microscopic polyangiitis with a P-ANCA positivity. No sinusitis. Granulomatosis with polyangiitis is going to be sinus, kidney, and lungs with a C-ANCA positivity. And eosinophilic granulomatosis with polyangiitis is going to be asthma and eosinophils with the P-ANCA positivity. Okay, so I want you to take away those key things. All right, so once again, eosinophilic granulomatosis with polyangiitis is going to be asthma with eosinophils and P-ANCA positivity. Granulomatosis with polyangiitis is going to be sinuses, kidneys, and lungs with C-ANCA positivity. Microscopic polyangiitis is solely kidneys and lungs, no sinuses, with P-ANCA positivity. Remember, P-ANCA and MPO-ANCA go hand in hand, myeloperoxidase, whereas C-ANCA and PR3-ANCA go hand in hand for antiproteinase 3. All right? Now, last two are immunoglobulin A vasculitides. This is the most common childhood systemic vasculitis, and it usually follows an upper respiratory infection. Remember, we discussed this in the renal section. Okay, so if you see a child with recent URI who presents with palpable purpura and melena, this is going to be immunoglobulin IgA vasculitis. Okay, palpable purpura on the buttocks and the legs is very key to IgA vasculitis. You're going to have stomach pain as well. This was formerly called Henoch-Schloen purpura, and once again, the vasculitis is secondary to IgA immune complex deposition into the vessels. It's associated with IgA nephropathy, Berger disease, BERGER, compared to the other vasculitis where we already talked about, but associated with that type of Berger's disease because those IgA immune complexes can also deposit in the glomerulus, causing the kidney abnormalities that we talked about in the renal. All right, and this is supportive care is what treats it. All right, lastly, mixed cryoglobulinemia. There's no red blood cell cast. It's often associated with Hep C, and pretty much that's all you need to know for mixed cryoglobulinemia. All right, so this is our vasculitides, and I'm going to run through it one more time for you to fully know what's going on, just the high-yield associations. 1, giant cell temporal arteritis. You have an elderly female with headache, pain on chewing, elevated ESR and IL-6. The feared complication is blindness because of ischemic optic neuropathy, and so you have to give glucocorticoids high dose before doing a temporal artery biopsy. Next is going to be Takayasu. It's going to be an Asian female with pulse abnormalities and a Brui herd over some of the great vessels. Next is our medium vessel vasculitides. We have first Berger disease, BUERGER, and this is due to smokers with nasty hands and feet, you'll likely see. That causes auto amputation of the digits. You'll see inflammatory intraluminal thrombi sparing the vessel walls. Kawasaki's disease is usually going to be an Asian child less than 4 years old with skin, lips, tongue, and conjunctiva affected. You can differentiate it from the scarlet fever by the presence of conjunctivitis and the absence of sore throat. A feared complication is going to be coronary artery aneurysms, and the patient is going to receive aspirin, the only time where a child receives aspirin. Next is going to be polyarteritis nodosa. It's a patient usually that's Hep B positive with nerve deficits, skin nodules, purpura, and renal failure with a string of pearls seen on kidney. You're going to have segmental transmural inflammation with fibrinoid necrosis. Fibrinoid necrosis is high yield. And you'll see renal infarcts and bowel infarcts, but the lungs will be spared. Okay? So it affects what they say affects the skin, the kidneys, the intestines, and the nerves. Next is our small vessel vasculitides. Eosinophilic granulomatosis with polyangiitis is asthma with eosinophils that are elevated and a positive P-ANCA or MPO-ANCA antibody, which is myeloperoxidase. You could see wrist and foot drop in this. Next is granulomatosis with polyangiitis. That's going to be sinus, kidneys, and lungs involved with a C-ANCA positivity or a PR3-ANCA positivity for antiproteinase 3. Both of those you will see granulomatous processes. It's going to be granulomas present. Next is microscopic polyangiitis. This is only kidneys and lungs involved, no sinuses, and it's going to be P-ANCA or MPO-ANCA positivity with no granulomas. Next is IgA vasculitis. This will be a child with recent URI, upper respiratory infection, that presents with palpable purpura and a lot of severe stomach pain, and it's associated with IgA immune complex deposition into the vessels. You're going to see it in association with the Berger disease seen in kidneys, BERGER, and that's because also known as IgA nephropathy. All right, so that's your end-all be-all for vasculitides. If you have any questions, please be sure to reach out.